Aortic stenosis is the most common valvular heart disease in the United States, afflicting 1.5 million Americans. And the problem of severe aortic stenosis is particularly challenging in the elderly patient. To provide us an update on the management of aortic stenosis, it's a pleasure to welcome back to the podium this year Dr. William Su. Dr. Su is an assistant clinical professor of medicine at UCLA in the Division of Cardiology, and he's one of our interventional cardiologists. Dr. Su.
Thank you. All right, good morning, everyone. Hope everybody's enjoying their time here in Las Vegas. So I'm going to be talking about aortic stenosis today. Here's a couple of disclosures. I do receive honoraria from Edwards Life Sciences. I serve as a TAVR proctor, so I actually teach other cardiologists how to do this procedure. TAVR refers to transcatheter aortic valve replacement, which I'll be talking about today. I'll also be speaking mainly on devices that are FDA approved, and I will point out if a device is being used off-label or if a device is not yet FDA approved. So here is an example of a coronary angiogram, and you can see here that there is a focal stenosis here in the mid-LAD. This is a patient that presented with unstable angina. And coronary artery disease has been the bread and butter of interventional cardiology for the last few decades. And this is the type of angiographic result that we can achieve after percutaneous coronary intervention with stenting. So now that you've learned from Dr. Watson about statin therapy and treating those patients at risk, and now you've also learned about treating diabetes aggressively and minimizing risk of future cardiovascular events, this is an example of what's been happening with acute myocardial infarctions over the last decade. So STEMI volumes have come down significantly over the last decade due to good medical therapy. And so interventional cardiologists have less work to do because we're not treating as much heart attacks. So it got a lot of interventional cardiologists thinking, well, what else can we do to the heart? So this brought up and introduced the whole field of interventional structural heart disease. So we are now able to put in devices into the left atrial appendage to help prevent stroke and atrial fibrillation. And recently, the FDA approved the Watchman device for that purpose. We can also close holes in the heart, either in the atria or the ventricle. So atrial septal defects, PFOs, and ventricular septal defects can all be closed now percutaneously if the anatomy is appropriate. And we can now treat valvular disease with transcatheter valves. So I'm going to mainly focus on the aortic valve position, and so there are now 2 FDA-approved devices for transcatheter aortic valve replacement, and that is the Edwards sapien valve and the Medtronic core valve. There are other devices in development for the other valve positions, so there is use of transcatheter valves in the mitral position as well as in the pulmonic position, but today we'll focus mainly on the aortic. So the aortic valve is a tri-leaflet valve that separates the left ventricle from the aorta. And normally these valve leaflets should be thin and pliable. And so this 3D transesophageal image shows you what a normal aortic valve should look like. The leaflets are opening up all the way, letting all the blood flow out of the heart, and it closes all the way, not letting blood flow back into the heart. So in older patients, what can happen is that calcium can deposit into the valve leaflets, similar to atherosclerosis, so usually lipid deposition into the valve leaflets, then over time causing recruitment of osteoblasts and then calcium deposition. And what happens then is that the calcium is rock hard, causes restriction in leaflet motion, and now in the 3D transesophageal image, you can see that this valve orifice now is a pinpoint hole, and that causes left ventricular outflow obstruction. So how is aortic stenosis diagnosed? Well, it's diagnosed simply with a tool that we use every single day, our stethoscope, and oftentimes the murmur of aortic stenosis is not subtle. You should be able to hear a loud, harsh, systolic ejection murmur at the right upper sternal border. that radiates usually to the carotids. As the aortic stenosis becomes more critical, the murmur becomes late peaking, so more closer to the A2 sound, and A2 actually starts to diminish. So if you think about it, A2 occurs because of the slapping of the leaflets in diastole, and that's what actually causes the second heart sound. With the valve leaflets not opening as much, you start losing A2 when the aortic stenosis becomes more critical. So primary physicians will hear the murmur and then order an echocardiogram, and that's how we'll diagnose if the patient has severe aortic stenosis. So there are certain echocardiographic criteria that we look at to define if aortic stenosis is in fact severe. So we look at the maximum jet velocity of the blood across the aortic valve on continuous wave Doppler, and if that velocity is greater than 4 meters per second, that would qualify as being severe. We also look at the pressure gradient across the aortic valve, and so a mean pressure gradient of greater than 40 millimeters of mercury would also then be considered severe. And then we can actually calculate an aortic valve area using the continuity equation. So we look at the velocity of the blood across the LVOT, the left ventricular outflow tract, and also get a measurement of the diameter of the LVOT to get an LVOT area. And then we then use the continuity equation since we have the valve velocity of the aortic valve, and then you use the equation to then calculate the aortic valve area. And so a valve area of less than 1.0 centimeters squared would then qualify as being severe. It's nice when all three of these metrics are consistent and show a severe aortic stenosis, but sometimes there are discrepancies, and we have to use either invasive hemodynamic testing or transesophageal echo to kind of define whether or not a patient in fact has severe aortic stenosis. So age-related calcific aortic stenosis is the most common form of aortic stenosis, and its prevalence steadily increases with age. And it's approximated that 3% of patients over the age of 75 have critical aortic stenosis, so you're going to see these patients in your practices pretty frequently. And it's a progressive calcification initially along the flexion lines at the bases that leads to immobilization of one or more of the aortic cusps that leads to the left ventricular outflow obstruction, and it's that obstruction that then causes symptoms. So what are the symptoms of aortic stenosis? So let's start up here. Let's go to the left side, and with the increase in the left ventricular systolic pressure due to the obstruction, over time you're going to get an increase in the left ventricular mass, so there's going to be more myocardial tissue. That can actually lead to increased myocardial oxygen consumption, and then eventually to myocardial ischemia. So one of the symptoms that a patient may have is angina. Over time, if this left ventricular mass continues to increase, you'll eventually start failing, and then you'll start developing left ventricular systolic dysfunction, and then leading to LV failure, and that will cause shortness of breath. And then on the opposite side of the valve, you're going to get a decrease in the aortic pressure, and that can cause lightheadedness, dizziness, and even passing out. So the three cardinal symptoms that you should remember for aortic stenosis are going to be syncope, angina, and heart failure. So this is what happens to patients that have severe aortic stenosis that are left untreated, and this was initially published by Dr. Eugene Braunwald in the 1960s. And so there's a very long latent period where there's no symptoms, and then survival precipitously drops off once symptoms appear. So the best survival are those patients that presented with angina, and they had an average survival of 5 years. Those patients that presented with syncope had an average survival of just 3 years, and then the worst prognosis were those patients that had LV failure, and their average survival was just 2 years. But look here, that this graph here is looking at patients that develop symptoms in their 50s and 60s, and oftentimes we're dealing with much older patients, and so the older patients have a much worse prognosis, and we estimate that if a patient develops heart failure in an elderly patient, their average survival is probably just 12 months. So severe aortic stenosis is pretty deadly, and to put things into perspective, looking at various cancers and their associated 5-year survivals, so let's compare breast, lung, colorectal, prostate, and ovarian cancer. The worst of these cancers is lung cancer with a 5-year survival of just 4%. Severe inoperable aortic stenosis has a 5-year survival of just 3%. So this is worse than some of our worst cancers. So it is important to identify these patients, get them diagnosed properly, and then treat them if appropriate. This is just to show that in the elderly patient, the 1-year survival is about 50%. So here's the treatment algorithm for patients that are diagnosed with severe aortic stenosis. And so they do have the echo criteria of severe aortic stenosis. If they are going to undergo another type of cardiac operation, then it's a class 1 indication for aortic valve replacement. All patients that are symptomatic and are surgical candidates, it's also then a class 1 indication for aortic valve replacement because we know that it improves survival as well as improves symptoms and quality of life. Sometimes patients adjust their lifestyle to not be symptomatic, and so in those patients, you can put them on a low-level treadmill to see if you can elicit symptoms, also to see their blood pressure response to exercise. If they're not able to mount a blood pressure response to exercise, and they either have a flat or even drop their blood pressure, those are patients that probably would benefit from valve replacement. If a patient has left ventricular dysfunction, and so an ejection fraction of less than 50%, that's another cohort that would benefit from AVR. So if a patient does not have symptoms at all and their left ventricular function is normal, these are patients that you can just follow clinically, maybe get serial echoes in 6 months to a year, and more frequent clinic follow-ups just to make sure they're not developing symptoms. Another thing that it might be useful is to trend brain natriuretic peptides, BNP, to see if there's a trend in increasing the BNP and to see if they're having progressive heart failure from that perspective. So there is also now this other newer entity that's being more recognized, and that's the low-flow, low-gradient aortic stenosis. And so these are patients that have gradients that are not less than 40, so more in the moderate range, but their aortic valve area does calculate to less than 1.0 centimeters squared. And there's 2 scenarios where this can happen. One is the patients that have low ejection fraction, so an ejection fraction of like 25, 30%. Their left ventricle is not able to mount that pressure response, and so they will have a low pressure gradient. But the other important cohort to recognize are those patients that have preserved ejection fractions, and so those are people that have EFs of greater than 50%. And in these patients, the gradient is low because the stroke volume is low because of the LVH. So the LVH then causes a small LV cavity. So because of the smaller volume of blood, they're not able to create a high pressure gradient. So a stroke volume index on echo of less than 35 millimeters per meter squared, that would be considered a low stroke volume. And so here is a different algorithm. I wanted to point out in this algorithm that those patients that have a maximum velocity of greater than 5 meters per second and are asymptomatic, these are patients that also may benefit from earlier intervention because the risk of sudden death is higher in these patients. And then to reinforce the low flow, low gradient with preserved ejection fraction patients, and those are the patients that have an LVF greater than 50%, aortic valve area less than 1 centimeter squared, and if the aortic stenosis is the likely cause of symptoms, then it is a 2-way recommendation for aortic valve replacement. So, as I mentioned already, in symptomatic patients with severe aortic stenosis, aortic valve replacement has been shown to improve both symptoms and survival. However, there has been no randomized trial comparing medical therapy to AVR, and this trial, will never be done. It's sort of equating this to jumping out of an airplane without a parachute. Everybody knows that, you're going to die if you don't have a parachute. So, for those patients that with severe symptomatic aortic stenosis, they will die if they don't get their valve treated. And so here's just a picture of what happens during an AVR. The surgeon opens the chest, transects the aorta, cuts out the diseased leaflets, and then sews in a new valve, and then closes up. But it is a procedure that does require cardiopulmonary bypass and all the associated morbidities with open heart surgery. So according to the ACC/AHA valve guidelines, aortic valve replacement is indicated in virtually all symptomatic patients with severe AS. Here is a survival graph of patients that had symptoms and no symptoms, and those patients that were treated with AVR and not treated with AVR. And so the cohort that did the worst in terms of survival were those patients that had symptomatic aortic stenosis but did not get their valve treated. Here are those patients that did or did not have symptoms but did get AVR, and those patients had the best survival. And these are patients that did not have symptoms, but and did not have AVR, but their their survival was better than those patients that had symptoms. But again, this is just to show that that AVR does improve survival. So a common question is age a contraindication? And at what age is too old? So the guidelines specifically state that advanced age is not a contraindication to surgery, but the decision to proceed with surgery in elderly patients depends on many factors, including patients' wishes and expectations. So in the PARTNER trial, which was the first trial looking at transcatheter valve therapy versus surgery, it was a randomized trial, 1-to-1 to either TAVR versus surgery. And the PARTNER trial actually had patients that were as up to 98 years old, randomized to surgery, and these patients actually did well. So it kind of proved that there isn't an absolute age cutoff for this therapy. So despite the ACC recommendations, a significant number of elderly patients do not undergo AVR because of comorbidities and the associated increased morbidity and mortality with surgery. And Young et al. In the European Heart Study showed that about a third of elderly patients with severe symptomatic aortic stenosis were denied surgery by their physicians. And then many elderly patients that are suitable for surgery actually just refuse surgery altogether because they just perceive themselves as being too old. So transcatheter aortic valve replacement has risen as a promising alternative therapy to open AVR in those patients deemed either inoperable or high surgical risk. So here's a picture of the very first transcatheter valve therapy that was done in Rouen, France in 2002. The stent is a pretty rudimentary design. The balloon is not very well crimped. But this procedure was a proof of concept, a first in man, that this is something that is technically feasible. And this is a picture of what the second generation sapien device looks like. You've got a nice tapered nose cone, a nice profile balloon, and then a stent delivery system that is much more refined. So there's two different types of transcatheter valves now available on the market here in the US, and it's the Edwards Sapien XT valve, which is the second generation device. It's balloon expandable, so this stent is then crimped and collapsed onto a balloon and can be delivered through a 16 or 18 French expandable sheath, and there's three different sizes for this valve, the 23, 26, and 29 millimeters. The other valve is the Medtronic core valve, which got FDA approval after the Sapien valve. It's a much different design. The stent itself is much longer. The metal here is a nitinol frame, and nitinol actually has shape memory, so this whole device can be then put into a catheter, and then once it's unsheathed, it will resume this shape and position. And it's also through an 18 French sheath, and there's actually four sizes, 23, 26, 29, and 31 millimeters. So to give you a visual of what this procedure is like, here's an animation of the procedure. And so this first animation is going to be the one on the balloon expandable sapien valve. So we get a guide wire across the aortic valve, and this guide wire is going to sit in the left ventricle. And that guide wire is going to serve as our rail then to be able to deliver our balloon and then eventually our stent. We advance the delivery sheath through the iliac artery. And over that wire rail, we're going to advance a balloon. And the first step of the procedure is to do a balloon valvuloplasty to crack that valve open to allow for more space then for our stent that needs to go in place. So here we're cracking the valve open. We're going to take that balloon out. And next, we're going to advance the stent delivery system. So this is an expandable sheath, and so the stent comes out. We're going to assemble the whole delivery system within the body. The engineers made it this way so that you can you can do this with a lower profile system. So once we assemble the whole system in the body, then we're going to advance the whole thing again along that wire rail. There's a flexing mechanism on the catheter to allow for easier passage across the arch. And then we're going to position this right at the aortic valve position. Once in position, we're going to inflate the balloon to expand that stent. The valve leaflets get pushed to the side, and it's the calcium within the valve leaflets that ends up serving as the anchor so that the device doesn't move. And then we take everything out, including the wire, and what we have here is essentially an aortic valve replacement that has been done going through the groin and not having to do open heart surgery. So here now you can see that this valve is opening and closing much better, allowing for much better blood flow to the heart. Now, one of the Achilles heels of this procedure is that since we're not removing the calcium in these leaflets, you can have leak around the valve. But the newer technologies that are going to be coming out hopefully in the next year or two are going to have ways to minimize that. So here's a fluoroscopic example of the procedure. Here we're rapidly pacing the heart. We're injecting contrast to make sure that the stent is in good position, and then we're going to slowly inflate this stent to then to implant this valve. And the actual valve implant for the balloon expandable is about this long. It takes about 15, 20 seconds. It's all the prep going into it that actually takes a longer time. So this is an animation of the other valve, the core valve. Yeah, just go down to the play on the bottom there. Yeah, there you go, thank you. So again, similar transfemoral access, and we're going to advance the core valve system over that wire rail. And instead of rapidly pacing and inflating a balloon, the valve is actually going to be unsheathed. And this does not require rapid pacing. A little bit different also is that the valve is actually going to be sitting above the annulus. The valve actually does sit a little bit taller than the sapien valve. It also ends up sitting also a little bit lower than the sapien valve, and that can actually cause conduction system disease, and the rate of permanent pacemaker is a little bit higher in the core valve patients. So this is just a picture of what happens during our procedure, and there's a lot of people in this room. This is a multidisciplinary effort. We have cardiac surgery, interventional cardiology, echo, anesthesia, our fellows, our NPs, our OR staff. So there's a lot of people, and there's about 20 people in the room when we do these procedures, and so it takes a lot of coordination of care. So just to go through some of the data behind this therapy, so this is the PARTNER trial. This was the first trial looking at transcatheter valve therapy compared to medical therapy in the cohort B and then surgical therapy in the cohort A. So let's talk about the cohort B patients first. So on this side, these were the patients that were deemed inoperable. They were seen by 2 cardiac surgeons, and they were deemed to be not surgical candidates. And so these patients were assessed if they had good transfemoral access. Then they would be 1-to-1 randomized either to transfemoral TAVR or to standard therapy, which could include balloon aortic valvuloplasty. And they were looking at the primary endpoint of superiority in all-cause mortality. So this was the 2-year data looking at the cohort B. So at 1 year, those patients that were treated with standard therapy, they had a 50.7% chance of death. At 1 year. Those patients that were treated with the TAVR, they had a 30.7% chance of death, so an absolute reduction in mortality of 20%, so a number needed to treat to save 1 life in 1 year was 5. So this was a big deal, and that benefit also was seen out to 2 years. Those patients that were treated with TAVR had significant improvement in New York Heart Association functional class symptoms. So, class 1 and class 2 are in this greenish color, and so many more patients in the TAVR arm were either in the green class 1 or class 2 heart failure. So the second part of the trial was the cohort A. These were patients that were deemed high surgical risk, and that was defined as having an STS score of greater than 10%. STS is the Society of Thoracic Surgeons, and they have a risk model, and you can calculate what their risk would be for open heart surgery. So if they had a 10% risk of mortality at 30 days after surgery, then they would be considered a high-risk patient. So these patients also were assessed that they had good transfemoral access. If they had good transfemoral access, then they were 1-to-1 randomized either to transfemoral TAVR or to surgery. If they did not have good transfemoral access, then they would be put into the transapical arm, and that's instead of doing it from the groin, make a small incision on the left side of the chest and go through the tip of the heart itself. They were then 1-to-1 randomized either to transapical TAVR or to surgery. And then their primary endpoint for this part of the trial was looking for non-inferiority in terms of all-cause mortality. So here is out to 3 years, and so the lines are pretty much equivalent. There's no statistical significance, and so this basically showed that transcatheter valve therapy was non-inferior to surgical therapy in the high-risk cohort. New York Heart Association functional class symptom improvement was very similar in both groups, so you can see that there's pretty much the same improvement on both the surgery and transcatheter arms. And then in terms of stroke, the first generation, this was done with the first generation system. The first generation system was a much bulkier system than what we have now, 24 French sheath for a 26 millimeter valve. And so in terms of stroke, we are advancing this large catheter across the arch vessels. And also there can be debris coming off of the valve when we do the valve implant. So there is a risk of stroke. So in the transcatheter arm, at 1 year, there was a 5.8% risk of stroke. In the transcatheter arm, there was a 3.0% risk of stroke in the surgical arm. So numerically different, but it did not meet statistical significance. But it is a trend. So I said the Achilles heel for this therapy is paravalvular regurgitation. And so moderate is in purple and severe is in red. And so there were many more patients in the TAVR arm that had either moderate or severe paravalvular regurgitation compared to surgery. And why does this matter? It matters because it affects mortality. But in those patients that had none or trace aortic regurgitation in the TAVR arm, and those are the patients here in blue, those patients ended up doing better than the surgical cohort. So this was an indication that if we can actually get better in the paravalvular regurgitation, maybe TAVR would actually be superior to surgery. So this was presented at the ACC March. And this was the core valve US pivotal trial. And they were looking at the high-risk cohort, and they were one-to-one randomized either to the core valve, which is the self-expanding stent, versus surgery. And here's out to 2 years. This trial actually showed that at 1 year, there was a 4.8% better survival in the core valve arm versus surgery. That benefit was actually seen out to 2 years. And so this is actually the first transcatheter valve therapy trial to show that TAVR is better than surgery, superior to surgery. Stroke actually was better in the transcatheter valve arm compared to surgery. So at 2 years, 16.6 versus 10.9, and that did meet statistical significance. The TAVR valve actually ended up performing better in terms of valve hemodynamics, so they were able to get better reductions in the pressure gradients compared to surgery. And paravalvular regurgitation still was an issue. So, 10% of patients still had either moderate or severe paravalvular regurgitation in the TAVR arm versus surgery, whereas in surgery, the chance of having some moderate or severe paravalvular regurgitation was very low. So the way that we sized the annulus was different between the two trials. So in the partner trial, the sizing of the annulus was mainly done by transesophageal echo, and then the sizing of the annulus on the core valve trial was mainly done by CT, and CT has really become the gold standard for sizing the annulus. So here's an example of a 3D reconstruction of the CT annulus. Here we're getting a level right below all three aortic cusps, and we measure this area. And we want to get about a 10% oversizing on this area so that we're actually stretching out the annulus to try to get the best seal. We can also, from this 3D reconstruction, also measure the coronary heights. Here's the left coronary artery, and we measure the height from the left coronary artery to the annulus, as well as the right coronary artery. And that's important because if the valve leaflets come up, sometimes if the sinuses of Valsalva are too shallow or the left main is sitting too low, there is a chance that we can obstruct the left main or the right coronary in these cases. And if we do find that a patient's at high risk for that, we may end up putting a coronary guide wire at the time of valve implant to minimize having a complication. So the only head-to-head study between the balloon expandable and self-expanding stent was this CHOICE trial. And this trial actually suggested that maybe the balloon expandable is superior. We're going to need, obviously, more studies because this was not a very large study. It was only 240 patients. But the device success was better in the balloon expandable versus self-expanding. Moderate or severe paravalvular regurgitation was better in the balloon expandable arm, 4.1%, versus the self-expanding, which was as high as 18.3%. So another major difference between the two devices is that the need for permanent pacemaker. So the core valve, the self-expanding stent, actually ends up sitting a little bit lower in the left ventricular outflow tract, putting more pressure on the conduction system of the heart. So there's more heart block seen with the self-expanding system. So in the balloon expandable arm, the pacemaker rate was 17%, whereas in the self-expanding arm, the pacemaker rate was 37%. So, and that did meet statistical significance. But in summary, both devices are very good and and lead to good outcomes and improvement in mortality and symptoms. So many centers have both, and we are planning on incorporating core valve into our system as well. These are just some pictures of some of the transcatheter valves that are in development. And some of these, specifically here, the Lotus valve has this outer seal. There's this material that will help capture the paravalvular leaks. And so, companies are working on trying to minimize the risk of paravalvular leak. The next generation sapien valve is probably going to be the next one to market, hopefully by the end of this year. And this actually has an outer skirt at the bottom of the stent that will help capture that paravalvular leak. And at the ACC meeting just this year, they actually presented the SAPIEN 3 30-day data. And so here is SAPIEN 3 high risk, so those patients that are high surgical risk, SAPIEN 3 intermediate risk, so these are STS scores between 4 to 8%. And what you're seeing compared to the historical, SAPIEN and SAPIEN XT, that the mortality actually is getting better and better with this therapy. So if you look at the intermediate risk cohort, we're getting a 30-day mortality of just 1.1%, which is extremely low, and actually is probably even better than open heart surgery, even in this intermediate risk patient population. The risk of stroke actually has gotten lower and lower with the devices, first generation, second generation, now third generation. So less than 3% risk of stroke with this procedure with the latest device. And then paravalvular leak, as I said, the SAPIEN 3 device has that outer skirt that helps prevent paravalvular leak. Paravalvular leak is now less than 4% with the SAPIEN 3 device. So we are anxiously awaiting the FDA approval of this device because I think that patients are going to do much better with this system. It's also a lower profile system. Right now, the SAPIEN XT valve, the 23 valve goes through a 16 French expandable system. This is now going to be down to 14 French, which is going to be pretty remarkable. And so many more patients are going to be able to be treated from the groin rather than from alternate access. So I mentioned already, so what about the lower risk patients? What about those patients that have an STS score between 4 to 8%? The intermediate patients are not able to, at this time, be treated with TAVR under FDA indications commercially. There are some trials that are going on looking at the intermediate risk patient population. So the Partner 2A trial, which is with the SAPIEN XT device, their enrollment has already been complete, and so we're awaiting data. The CERTAVI trial, which is the core valve trial, that trial is ongoing. But difficulty in actually enrolling patients because many patients now realize that this is a therapy that even in the intermediate risk patient that is beneficial, and many patients just don't want to be randomized to surgery. They don't want to roll the dice. So what are the characteristics of a TAVR patient? Age definitely plays a factor. If they have a reduced ejection fraction, that puts them at higher risk. If they have peripheral vascular disease, that means that there's a higher atherosclerotic burden. Those are patients that are at higher risk in terms for surgery. If they have a heavily calcified aorta, the so-called porcelain aorta, they may be deemed inoperable. And severe lung disease actually ends up being a big factor in terms of the risk assessment. So there's an online calculator. You can just Google STS score, and it'll take you to an online calculator, and you can actually just input your patient's demographics and kind of see what their surgical risk would be. And it's actually pretty surprising because you can actually put a patient in that's 90 years old, but otherwise healthy, and their STS score will be like 3%. So you have to have some other comorbidities to actually really get their STS scores to greater than 8%. But there are many patients that have a low STS, but are considered frail. And so some of the objective things that we can look at to assess for frailty is, are they independent in their activities of daily living? What is their nutritional status? What's their overall strength? We can do hand grip strength as a marker for that. Have they had any falls? Frequent falls is a marker of frailty. And then if there's any dementia, people say, you don't get any smarter from going on cardiopulmonary bypass. So it might probably be best if they have dementia that we can treat them transcatheter where we don't need to put them on bypass. So here's just an extra example of how, this big delivery sheath going through the aortic vessels. It's pretty bulky. So we have to make sure that the iliac arteries are big enough to be able to accommodate this bulky sheath. And so CT ends up showing us a lot of detail. Here is a reconstruction of both the left and right iliac arteries, and you can see that where there's levels of calcification and just measure the diameters and dimensions of throughout the aorta iliac vessels to make sure that access is good for this procedure. But if the access is not good, then I already mentioned that there is the alternate route access. So here is a picture of what a transapical access would look like. So the surgeon makes a small left thoracotomy, exposes the tip of the heart, and then we'll go through the tip of the heart itself. Alternatively, the surgeon can make a sternal incision, a high sternal incision, and then the aorta can be accessed directly. This is what we call the transaortic approach, and it will still be a retrograde, a cross aortic valve in a retrograde fashion, and many centers are incorporating this as an alternative technique as well. So I just wanted to go through a couple case examples quickly. So here's an 82-year-old female who in July 2012 presented with acute heart failure. She was previously known to have severe aortic stenosis but was asymptomatic, so her cardiologist was clinically watching her. But an echo on that admission showed that her ejection fraction went from normal, 60%, all the way now down to 20%. So because of her cardiomyopathy, she was referred to us for TAVR. So here's a picture of her left ventricle at the time of the procedure, and this ventricle is ballooned out. It's very dilated, and the ejection fraction is even lower than 20%. It's now more like 10, 15%. So we got very worried about her during this procedure. So her left ventricular volume was very high at 251. So when we looked at our mitral valve, we saw that there's severe mitral regurgitation, which was not previously recognized, and this is probably because of the worsening heart failure and dilation of the mitral annulus, causing functional mitral regurgitation. So this also posed another challenge during the procedure. So here's the very narrowed aortic valve, and then there's also a moderate aortic regurgitation. So this ventricle was getting volume and pressure overloaded due to all this regurgitation, as well as the aortic stenosis. And at this time, the anesthesiologist is now telling us that the patient's becoming hypotensive. The patient was started on epinephrine for support, and so we had to decide whether or not to abort the case and not do it because she's too high risk, or should we go ahead and proceed with hemodynamic support. And so we figured that she would die without this therapy, so we went ahead and put her on cardiopulmonary bypass peripherally through our femoral artery and vein cannulation, and then went ahead with the procedure. And, oops. So here's now what happened after the sapien valve implant. Now you can see that the stent is here. You've got these leaflets that are opening and closing nicely. There's no aortic regurgitation, no paravalvular regurgitation. And also it looked like that the mitral regurgitation also got better, which surprised us. So now this is a picture of what her ventricle looks like now. It's much more slender. This is immediately after valve implant. Ejection fraction now acutely has gotten better to 25%. And the left ventricular volume was 250 before, now it's 168. So we saw a marked improvement right away. And this is what the mitral valve looked like now. There's absolutely no mitral regurgitation. So we ended up fixing 2 valve problems with just 1 transcatheter valve. And we ended up publishing this in JACC afterwards because we saw such a great result. And in 1-year follow-up, her ejection fraction actually went back to normal. Her ejection fraction is now back to 60%, and she's living a normal life. So another case, 57-year-old female who had Hodgkin's lymphoma as a teenager and got extensive chest radiation. And because of all that chest radiation, got a lot of calcific heart disease and mainly severe mitral regurgitation, severe aortic stenosis, as well as coronary artery disease. So she underwent mechanical MVR, but the aortic valve was not done due to a porcelain aorta. So within the porcelain aorta, the surgeon has nowhere to cross-clamp the aorta because if you actually take a clamp across that aorta, it's just going to fall apart. So she was referred for transcatheter valve therapy, and we ended up having to do her as transapical access because her femoral arteries were too small. So here's just a picture of what we started with. So here's the catheter coming from the apex of the heart. This circle here is her mechanical mitral valve. This is a TE probe. And then here is the sapien valve being positioned across her aortic valve. Okay, never mind, we'll skip it. So anyway, we successfully implanted this aortic valve in the aortic position, and everything was fine post-operatively, went home in 5 days. But then at a 2-week follow-up, she ended up presenting with more shortness of breath and a new murmur. And so we ended up getting a CT scan on her. Oops. And the CT scan actually showed that she ended up having a traumatic ventricular septal defect. So here is one of the struts of the sapien valve. Here's the right ventricle, here's the left ventricle, and here's this gaping hole between the ventricles. So she had a traumatic VSD. You can see that there's this gaping hole between. That's what the cause of the new murmur was, and for her symptoms. So looking back at her pre-intervention CT, there was this spicule of calcium that was in the left ventricular outflow tract that actually then got pushed into the septum and then eroded and caused this traumatic VSD. So we ended up putting a plug into that hole. And so now you can see that here's her mechanical mitral valve, here's her aortic valve, and then a muscular VSD occluder closing up the VSD, and then she ended up having improvement in her symptoms. Unfortunately, she ended up passing away a year later because of worsening pulmonary hypertension and other complications from her calcific problems from her heart disease. So this is something that's really exciting. So this is a 91-year-old man who had previous CABG, aortic valve replacement, and mitral valve replacement, and then presented with severe aortic regurgitation due to prosthesis degeneration. So, we typically say that these valves last about 10 to 15 years. And so, unfortunately for this gentleman, this is his aortic valve, this is his mitral valve. This aortic valve degenerated and had a severe leak. And he's 91 years old, has already had 2 prior open heart surgeries, so he was at high risk for having a repeat operation. So, although this would be an off-label use of the sapien device, we ended up getting insurance approval to do this, and we ended up fixing him and getting him better with a sapien implant in the aortic valve position. So here's a picture of what his Hancock 2 bioprosthetic valve would look like. Here's what it would look like on X-ray. And they actually, there's an iPhone app that actually tells you how to do this procedure, believe it or not. And they actually give you all these pictures where it tells you exactly how to place this sapien valve in this bioprosthetic valve. And so using this as a roadmap, yeah, they should have a better app for diabetes, right? Okay, so using this app, if I can now advance forward, come on. It's not, oh, come on, there we go. One more, come on back. Okay, so here we have a transapical access again. Here, the sapien valve is positioned with the upper part of the valve right at the level of these 3 rings, and then we're going to inflate this valve, and this is what the new valve and valve look like. So the sapien valve is not FDA approved for this indication, but the core valve just recently ended up getting FDA approval for this indication, and we should be anticipating that both valves will be FDA approved for this indication shortly. So the question is TAVR the real deal? And I think that with the latest data, it's showing that it is the real deal. And in fact, it's probably superior to surgery, even in the intermediate risk patients. But we have to wait for the data to be presented and published. But just to point out here that here in the guidelines, TAVR is a reasonable alternative to surgical AVR in patients who meet an indication for AVR and who have high surgical risk. So TAVR is the real deal. And just to kind of show you, every patient that gets this procedure in the United States is then placed into the TVT registry, which is a national registry. And up to February 2015, over 30,000 TAVR cases have been done in the United States. And we'll be collecting more and more data with the commercial experience as time goes on. So this is a picture of what interventional cardiologists and cardiac surgeons have been doing for the past few decades. The cardiac surgeon has been feeling beat up by us because, we're taking away a lot of their business from PCI now to valves. But as I showed you, this is a multidisciplinary effort, and so we are learning to coexist with our cardiac surgeons, and we are learning from our surgical colleagues every day as well as they're learning from us. So we do this as a team. And so why the heart team approach? It's because the patient is the one that benefits the most from this. We have cardiac surgery, interventional cardiology, cardiac imaging, cardiac anesthesia. We're all participating in this patient's care, so we're all bringing our expertise to the table. And not all patients are suitable for TAVR, and so I just want to point out that surgical aortic valve replacement at the moment is still the gold standard, so patients need to be evaluated by a multidisciplinary team. And the patient gains the most benefit because therapy is tailored to what is best for each individualized patient. So this is just all the members of our heart team, and I just want to thank you for your attention.
We got time for a few questions. If you have a question, raise your hand and we'll get you the mic. Why don't you go ahead?
So the long-term durability is unknown, and we advise that to our patients. So the procedure itself has been done about 9 years in Europe. So for all intents and purposes, we think that this valve is going to be just as durable as a surgical valve replacement, but we need to wait for the long-term data. We don't know that for sure.
Do you anticoagulate these patients?
So the optimum anticoagulation really is unknown. Taken from the coronary stent realm, patients are oftentimes treated with aspirin as well as Plavix, anywhere from 3 to 6 months. But if you look at the surgical patients that have bioprosthetic valves, usually just aspirin therapy is recommended. We're not entirely sure, do these patients absolutely need Plavix? But right now, for the moment, patients are being treated with aspirin and Plavix.
How many institutions are actually doing this procedure?
How many?
Yes.
I think across the country, a little over 300 facilities are doing this procedure. There's certain requirements that a facility has to have before being considered. There is a document called the National Coverage Determination, and the hospital has to perform a certain number of surgical AVRs. A certain portion of those patients have to be high risk. The facility also has to perform a certain number of coronary interventions, and they have to have physicians with the proper expertise in structural heart disease. So that's all outlined in the National Coverage Determination. So not all facilities are candidates.
And also, for an elderly patient over 90 who really is healthy, what is the surgical risk overall, a non-frail elderly patient?
That's individualized to each patient, and that's where the STS risk calculator comes in. So, the presence of hypertension, presence of diabetes, atrial fibrillation, vascular disease, what's the patient's height, what's the patient's weight. These are all things incorporated into STS. So you can have a 90-year-old patient that has an STS score of like 2-3%, and they would be low risk. You can also have a 90-year-old patient with really no other risk factors, but have, for instance, a low body weight. A little old lady with a low body weight, they actually may end up falling into the high-risk candidate just because of their frailty. So it's individualized to each patient, and you can do the STS calculation just by going onto that website.
With these other approaches like the transapical, do you get leaks, or do you have to put in some kind of plug or something?
So the surgeon actually ends up putting pledgeted sutures onto the apex of the heart, and so once the delivery system is removed, those pledgeted sutures are cinched up and actually closes the hole.